With the global population aging rapidly, trauma in the elderly has become an increasingly important area of concern. Elderly patients often present with multiple comorbidities, altered physiological reserves, and higher risk of complications, making their management uniquely challenging. Understanding the role of frailty and comprehensive assessment tools has been essential in the predicting outcomes and tailoring care to improve survival and the quality of life.
So our next plenary will focus on geriatric trauma. And to chair this, I would like to invite Dr. J. Gunadeepan, Consultant General and Trauma Surgeon at Kalbola South Teaching Hospital, and Dr. Manjula Patrina, Consultant General Surgeon at National Hospital of Sri Lanka.
Good evening. The now topic is the geriatric trauma. We call upon the Priya Samarasinghe from the Australia. She is a general and laparoscopic surgeon with subspecialty training in trauma and surgical critical care. Currently working as a general surgeon in the Solheavens District Memorial Hospital, New South Wales, Australia. Over to Dr. Priya.
So today I'm going to speak about importance of frailty assessment in the elderly trauma and how to predict outcomes. So it's a very important topic, but I would like to start with this phrase where's next slide. Oh yeah, so I would, so I would like to start with this phrase by Abraham Lincoln, which states, in the end, it's not the years in your life that count, it's the life in your years. So I'm going to talk about a few topics, elderly trauma burden, in Sri Lanka and in Australia, as well as what is frailty, what is chronological age versus frailty, why is frailty assessment important in the elderly trauma, and what are the tools used to assess the frailty scores and research findings, and how to implement frailty assessment in trauma care. So as we heard in the morning, elderly trauma burden is going to increase, and by 2050 we are looking at 25% to 30% to be elderly trauma patients presenting to hospitals. At the moment, 1/3 of the trauma presentations are elderly trauma, that is above 65 years, and we know that the outcomes are poor in this category. And in the Australian-New Zealand Trauma Registry, 2019-21 financial year showed that the severely injured elderly trauma made up of 31% of all the trauma presentations. And the 4 years prior to that, it was just, there was 21% increase in elderly trauma presentations in 4 years. Sorry. Yes, sorry. So how do we predict outcomes of these elderly patients? Do we go on their chronological age? Do we assess their functional status? Or do we assess their mental capacity? Or we just go on their history and comorbidities? Or we get a geriatrician to come and do a comprehensive geriatric assessment? So it is important to understand that the chronological age does not necessarily equate to a biological age. So the chronological age is different from the biological age. Each person is different. So we'll look at the definition of frailty. Frailty is a state of increased vulnerability due to reduced physiological reserve, due to end organ insufficiency that leads to high mortality, morbidity, and poor outcomes, and even death. And it is important to understand that the frailer patients have a greater risk of death, and everyone in the same age does not have the same risk of death. So when we look at age and frailty, if we compare, so the age, that is the chronological age, is the number of years a person has lived, whereas the frailty is the reduced physiological reserve due to age-related end organ insufficiency. And chronological age is time since birth, whereas the frailty is functional status and biological aging. And we assume in chronological age that everyone ages at the same rate, whereas in the frailty, it's highly variable between two people of the same age, and it differs. And predicting outcomes, chronological age has very poor in predicting outcomes, whereas frailty is a strong predictor of outcomes, complications, and mortality in trauma patients. And how do we assess this? So age, of course, we know from the date of birth. Frailty, there are several assessment tools that can be used to measure the frailty of the individual. One is a comprehensive geriatric assessment, or else we can use a simple method like Rockwood Clinical Frailty Score, and there are many other tools as well available. So as I said, why is assessing frailty important? Because in the past, we sort of made medical decisions and intervened according to a person's age, or maybe looked at their comorbidities. As a result, many healthier older adults were refused treatment, and that would have benefited them, and the younger patients who were frail were treated and without any benefit. So it's very important that we look at this frailty in elderly. And also the frailty commonly affects low socioeconomic disadvantaged people. It causes loss of independence, high cost to the healthcare and hospitals, and also it brings about a huge burden, especially in Sri Lanka, where extended family looks after the elderly. So it reduces their income and brings burden to young families. And like in places like in Australia, there's more expenditure to aged care and premature residential care placement. So do we assess these patients on history alone, or do we assess objectively of these individual elderly trauma patients, looking at their social circumstances, Do we assess their cognition, assess their mobility and nutrition, mood, or are we going to assess each and every patient how they are able to perform their daily activities? This will take a long time to do for each patient. So do we get a geriatrician to come and assess each and every trauma patient, elderly trauma patient? That would take a lot of time. So there are simple methods of assessing this frailty. One good tool is the Rockwood Clinical Frailty Score that has demonstrated to be in strong agreement with the geriatric assessed frailty scores, and it takes minimal time and minimal training required as well. It's easy to use tool. So this tool, which is the Rockwood Clinical Frailty Scale, evaluates patients' mobility, energy level, physical activity, function, independent and extent of dependency, medical disease status, as well as cognition. It has a score between 1 to 9, 1 being very fit and 9 being terminally ill. So this is the chart. You can have a look. This can be easily downloaded as well, and it gives a very good sort of a description of what to assess. And as you can see, the first one is very fit, active, and so 1 to 3 are non-frail, 4 will be like pre-frail, and 5 onwards is frail patients. So looking at it, they look at the activity, medical conditions, whether it's controlled or not, are they independent, dependent, and to what extent they are dependent on someone else, and their quality of life and everything is assessed in this clinical frailty scale. So looking at a few of the research papers, I came across this study, which is a systematic review and meta-analysis that was published in the Journal of Trauma in 2020. It looked at the impact of frailty on post-traumatic outcomes in older trauma patients. This comprised of 13 studies, 7 prospective and 6 retrospective studies for patients 50 years and above, and they looked at 50,000 patients. And the outcome of this study was that there was a significant adverse impact on 30-day mortality, post-operative complications, and readmission rates. So this is a study that we conducted at Level 1 Trauma Center in West Sydney. This was using the Rockwood Clinical Frailty Score to predict outcomes in the 12 months post-injury. And it was published in the Journal of Trauma and Acute Care Surgery, July this year. It's a very good paper examining the effect of trauma on frailty trajectories in older patients. So this was conducted, as I said, in a Level 1 trauma center, that's Westmead Public Hospital, New South Wales, Australia. All the trauma patients above 65 during 1 year period were recruited into this study, which we recruited 224 patients. The hypothesis of this study was that trauma would negatively affect an older person's frailty at 3, 6, and 12 months post-injury, and that frail patients would experience worse outcomes in the 12 months post-trauma compared to pre-frail and non-frail patients. So the data we collected were So we collected age, sex, mechanism of injury, comorbidities. For that comorbidity assessment, we used the Charleston Comorbidity Index to predict the comorbidity. And also we assessed the frailty score, pre-injury, then at 3 months, 6 months, and 12 months. And we took as non-frail 1 to 3, pre-frail 4, frail 5 to 9. And also we looked at the injury severity score, abbreviated injury scale, GCS, traumatic brain injury, in hospital, and 12-month mortality was looked at, hospital length of stay, ICU admission length, type of surgery during admission and complications, discharge destination also was looked at, and inpatient complications. And we looked at re-injury and readmissions to the hospital as well at 3, 6, and 12 months. So the key findings from this study was from falls from standing height accounted for 49% of the elderly trauma and 77% in frail patients, because obviously the frail patients would be falling from standing height, whereas the non-frail people would be climbing ladders, driving, and so that's why the percentage is less when you look at the whole cohort. By 12 months post-injury, when we looked at all the data, 1 in 3 frail patients were re-injured. And so that's significant. And 1 in 4 frail patients died. So that's like, even if you treat them, most of them, sort of when you assess them over 1 year, the frail patients, 1 in 4 frail patients would die. And none of the elderly trauma patients got back to baseline at 12 months. So that's also very interesting, because even if they were pre-frail, non-frail, still they didn't come to their baseline. So this is the data analyzed, and sort of the same thing. So significant findings were that according to the comorbidity Charleston index, it was significant because the frail, pre-frail, non-frail group, and the same as I said earlier, disposition and length of stay, all that were. So this is the graph that's showing that pre-frail patients, sort of non-frail patients became pre-frail in 3 months, and then at 12 months they did recover, but they didn't come back to the baseline. And in the pre-frail group, they also almost came close to being frail, but they never came back to the baseline, and the frail patients also declined and never came to the baseline. But we have to remember the 1 in 4 who, there was a mortality of 1 in 4 in frailty, so though they were not taken in this graph. So in hospital mortality in the frail group was 12%, and 12-month mortality was 28%, and trauma readmission rate was 36%. This is really significant. And also pre-frail also at 12 months had a 20% mortality rate. So so outcome of this study is that Assessing the frailty score pre-trauma, we can predict the trajectory of recovery following trauma, helps in decision making about medical management and surgical interventions. This allows early communication with patients and families on likely outcomes, and also can plan discharge destination and quality of life. And also we can predict the inpatient mortality and 12-month mortality. So at admission, this allows us to make advanced care plans for these elderly trauma, and also make medical and surgical plans on how we are going to manage this patient, and also think about where the discharge destination would be. And also this study allows us to predict operative complications, length of hospital stay, and readmission, re-injury rates, and need for rehabilitation, as well as nursing home, and also implementing falls prevention strategies that will need to be discussed with geriatricians. So how do we implement this frailty assessment into the hospital system? So like if in Sri Lanka it's not already happening, a member of the trauma team on admission will have to sort of assess the frailty score for the patient as part of the history taking, and use this score to predict the outcome and decision making for the management of this elderly trauma. So the main take-home message from this study is that Sri Lanka probably can implement into their trauma care is to develop protocols to assess the clinical frailty score in managing elderly trauma above 65 years. And this everyone can probably in the trauma team have a pocket card or download the image of one of those frailty score assessing tools on their mobile, and use that to assess these patients. And also these scores will then allow you to predict the patient's outcomes, and also help in discharge planning. And also as a country maybe look at how to prevent falls in elderly patients above 65 who are frail, so that we can prevent this sort of trauma in the future. That's it. Thank you.